Good morning, and I'd like to thank the Life Group for inviting me to talk again this year. I'm going to speak on the clinical updates that we've seen in the setting of GIST, and the majority of these have been in the metastatic setting, so that's what I'm focusing on today. So, as we've heard from Ping-Chi, the molecular classification of GIST is exceptionally important in terms of guiding therapeutic selection. And we know that the majority of GIST harbor mutations in KIT or PTGF-alpha, and the majority have mutations in KIT exon 11, which is the membrane domain. Versus those that have, there's a small proportion that have KIT exon 9 mutations in the extracellular domain. And then we have those with PTGF-alpha mutations also. And then further looking at molecular classification, it can be broken down into those with KIT or PTGF-alpha mutant GIST versus those with wild type GIST for KIT or PTGF-alpha. This group is broken down into those with SDH deficient GIST versus those with non-SDH deficient GIST, which can incorporate patients with other forms of GIST with other mutations in perhaps NF1, BRAF, RAS, and those with receptor tyrosine kinase translocations. And then there are the very small proportion of patients that are what we call quintuple wild type, and we haven't identified the molecular makeup of that tumor. And so with the metastatic setting in the first line, as we all know, imatinib represents the first-line standard of care treatment, and we know that it is a very effective drug in that it yields response rates of 50%, with a further 30% of patients benefiting in terms of stabilization of disease. And the median progression-free survival is approximately 24 to potentially 36 months. We know also, though, that imatinib is cytostatic and not cytotoxic. We know this from the fact that we see a very small proportion of patients obtaining complete responses. And even in that setting, when a complete response is achieved, we know that there is most likely residual disease there that has been placed into, let's say, a dormant setting. And this study by Johnny Clay in 2007 looked at giving imatinib to patients with advanced GIST in the first-line setting, and giving, after a year of therapy, randomizing patients to either treatment interruption or continuation of therapy. And those who were in the treatment interruption arm had a significantly higher rate of progression, 81% versus 30%, and this happened at a significantly greater or shorter time interval, 6 months versus 18 months in those that continued imatinib. Sure. In the second line and third line setting, we know that we have sunitinib and regorafenib approved. Sunitinib has yielded response rates of approximately 7% and a median progression-free survival of right 6 months. Whilst regorafenib in the third line setting can yield a response rate very low of 4.5% and a median progression-free survival of about 4.5 months. So why is it that after utilizing imatinib in the first line setting that we see such poor response rates from subsequent tyrosine kinase inhibitors? For the most part in KIT mutant GIST, this is due to the development of secondary KIT mutations, which occur either within the ATP binding pocket, which are KIT exon 13 or 14 mutations, or alternatively mutations occur within the activation loop, which reflects KIT exon 17 or 18 mutations. So ultimately, if this represents a significant proportion of patients why they fail initial frontline therapy, trying to identify therapies that will target these specific mutations is exceptionally important. So beyond the standard of care, what are the options to consider? And obviously we are huge proponents of clinical trials. And beyond that, we're looking at compassionate access programs for particularly the promising drugs that we're currently able to have the benefit of accessing at this time. So one of these is ripretinib, also known as DCC-2618. And this is a novel oral type 2 kinase switch control inhibitor of KIT and PDGFR-alpha. It also does inhibit other targets such as CSF1R, VEGFR2, and TIE2, but it's ultimately designed to inhibit a broad spectrum of KIT mutations in exon 9 right through to 18, and PDGFR-alpha in exon 18, including DA42B. So it's essentially targeting our primary and secondary KIT and PDGFR-alpha mutations. So the first study, it was a phase 1 study utilizing this therapy. The objective, obviously, to identify the safety of this drug, the recommended phase 2 dose of the drug, and ultimately the study had a 3+3 standard design, incorporating patients with advanced or refractory KIT or PDGFR-alpha mutant cancers, focusing on GIST, but there were also other subtypes included, other cancer types included, and dose levels ranged from 20 to 250 milligrams with schedules of once daily versus twice daily. And the second part of the study was an expansion, utilizing the recommended phase 2 dose, which was identified as being 150 milligrams once daily, with the opportunity for intra-patient dose escalation to 150 milligrams twice daily once RECIST progression had been evident on radiologic imaging. And the focus here was on GIST cohorts in the second or with patients with disease within the needing second or third line therapy or fourth line and beyond. So in terms of safety, this drug appears as what we're seeing in clinic, a very safe and tolerable treatment. Dose reductions were required due to treatment-related adverse events in 14% of cases, and treatment discontinuations occurred in 11%. I've highlighted some of the adverse events, but actually my slide has adjusted this. But what I wanted to highlight was that alopecia rates in, let's say, grade 1 and 2 were 50%. Hand-foot syndrome was approximately 32%, again, grade 1 or 2. Hypertension occurred at a rate of about 12%, grade 1 and 2, but there was 6% at grade 3 or 4. And then also the other was anemia, which had a 6% rate in the grade 3 or 4 setting. Looking at activity, we see promising activity across all lines of therapy. Focusing firstly on the second line, the objective response rate achieved with DCC-2618 was 18%. And comparing that back to sunitinib, which the objective response rate for was 7.5%, this is a lot better. And in terms of median progression-free survival, here we see it to be 42 weeks versus it was approximately 6 months in the sunitinib trial. We shouldn't do cross-comparison trials, but we do. In the third line setting, the objective response rate is 24%, median progression-free survival is 40 weeks, and then in the fourth line setting and beyond, we see an objective response rate of 9% and a median progression-free survival of 24 weeks. And we must note in this setting, really, imatinib-free challenge is the current standard of care approach in the fourth line setting and beyond, where we see objective response rates of 0% and median progression-free survival is approximately 2 months. So, with respect to ongoing trials and what we've seen from this data so far, it's demonstrated broad profile of inhibition across a range of primary and secondary KIT mutations and promising anti-tumor activity across GIST patients in all lines of therapy. The Invictus phase 3 trial is that of DCC-2618 versus placebo in the fourth line setting and beyond. And then the INTRIGUE trial is a phase 3 trial, randomized trial of DCC-2618 versus sunitinib in the second line setting. And then moving to the other agent that we have been utilizing in our clinics is Blu-285 or avapritinib. And this drug is designed to preferentially interact with the active conformation of KIT or PDGFR-alpha mutations. And it potently inhibits activation mutants such as KIT D816V or PDGFR-alpha D842V with sub-nanomolar potency. And it does inhibit other well-characterized disease-driving KIT mutations both in vitro and in vivo in preclinical models. And in the preclinical setting, broad screening against a large panel of human kinases revealed that BLU-285 had limited potential for activity outside of PTGFR or alpha. And BLU-285 was also more than 150-fold more potent on KIT D816V than several important kinase anti-targets such as VEGFR2, SRC, or FLT3. So this suggests that the off-target inhibition in vivo would be unlikely. And then also in the preclinical setting, it was shown that BLU-285 was active across the spectrum of clinically observed KIT mutants. So here in this graph, it was comparing to BLU-285 to imatinib, and it had very good activity in the activation loop mutations, so KIT exon 17 or 18, but less so in the ATP binding pocket mutations in KIT exon 13 and 14. I think that's important to highlight. And then ultimately, this led to the phase 1 study of BLU-285 or avapritinib, the Navigator trial. And the first phase of this study was to determine the safety, the maximum tolerated dose, and the recommended phase 2 dose. And then the second part to look at the response rate, duration of response, and safety. And ultimately, in the first phase portion of this study, incorporating patients with advanced GIST, we see a maximum tolerated dose of 400 milligrams once daily, and the recommended phase 2 dose was 300 milligrams once daily. And then the part 2 looked at different cohorts of GIST patients, including PTGFR alpha D842V, then patients in the second line setting, third line setting, or fourth line setting and beyond. And looking at the patient and tumor characteristics, the main thing here, just to note, is the GIST mutational or molecular classification. So the majority did have KIT mutant disease, 72%, and then the D842V population was 24%, and then the PTGFR alpha mutant non-D842V cohort was 4%. In terms of adverse events, here this graph shows adverse events occurring at a rate of greater than or equal to 20%. The majority of adverse events were grade 1 and 2, and 8.7% of patients discontinued treatment due to treatment-related adverse events. There were no treatment-related deaths. And in terms of the adverse events that we see, it is comparable to other tyrosine kinase inhibitors that we utilize for this disease. But what I will say, what we are noticing in the clinic is with regards to memory impairment, maybe to a greater degree with this drug than what we've seen from before. And although it's really reported here as being grade 1 or grade 2, this may be significant clinically, even at a grade 2 for our patients. It's something just to be mindful, very mindful of when utilizing this therapy. And then in terms of clinical activity, this is an impressive graph. And it focuses on the activity of BLU-285 in the PTGFR alpha D842V cohort. And we see an objective response rate of 84% with a clinical benefit rate of 96%. So for a disease subtype where we had we had nothing other than truly surgery, this is a remarkable achievement. And we see that these responses are durable, and we see a 12-month duration of response of 76.3% and a 12-month PFS rate of 81.3%. And this is a case from this cohort of patients. And you can see the image, the radiologic image on the left-hand side of your screen shows the baseline image, and then the 8-week image adjacent to that, showing a significant reduction in size. So just after 8 weeks of therapy, a 31% tumor reduction per RECIST. And this patient had prior lines of therapy, including imatinib, dasatinib, and crenolinib. And this case also includes ctDNA analysis. So at baseline, the ctDNA mutant allele fraction for D842V was close to 0.1 and dropped immediately to almost 0 after a minimal period of time on therapy. So looking at BLU-285 activity across, let's say, KIT mutant patients in the second line setting, it's also meant to say and beyond. So in the second line setting, we see an objective response rate of 25%. and the median progression-free survival has not been reached. So again, we see a comparison at the very bottom for what we currently have available as a standard of care, which is sunitinib. And then in the third or fourth line setting, which were regorafenib naive patients, we see an objective response rate of 26% and the median progression-free survival of 10.2 months. And then in the fourth line setting and beyond, the greater than fourth line setting, we see an objective response rate of 20% with a median progression-free survival of 5.5 months. This is an important slide that I will refer to again in a subsequent talk. And this was important information, I feel, looking at the activity of BLU-285 in the setting of advanced GIST in the fourth line setting and beyond. It's ultimately showing that BLU-285, we were seeing activity for patients who are negative for KIT exon 13 and 14 mutations, so those ATP binding pocket domain mutations, whereas those with positive exon 13 and 14 mutations were not seeing as great a role for BLU-285. So in terms of the clinical impact, based on the data from the Navigator study, avapritinib was granted breakthrough therapy designation by the US FDA for the treatment of unresectable and metastatic PTGR-alpha D842V mutant GIST. And encouraging activity in the third and fourth line regorafenib naive GIST cohort supported opening the Voyager randomized controlled phase 3 trial of BLU-285 versus regorafenib, which continues. And then I just want to slightly touch on immunotherapy in GIST. So GIST is an immunogenic tumor, and we've seen this from preclinical work performed by our colleagues at MSK, like Kavner and Rhonda Mateo, who have both since left to other institutions, and the Nobel who continues their work. We know that in imatinib-sensitive GIST preclinical models, we see higher ratios of CD8 cytotoxic T cells to CD4 or T regulatory T cells. And we know that we see greater imatinib activity when the CD8 T cell count is higher. And we also have seen that imatinib produces this immune stimulatory microenvironment through downregulation of IDO1. And IDO1 is an intracellular enzyme that converts tryptophan to kynurenine. And kynurenine causes an immune suppressive microenvironment. So reducing IDO1 and its activity should, in theory, increase your tumor microenvironment to be a more immune stimulated one, where potentially drugs such as immune checkpoint inhibitors may be able to be more effective in that setting. And so in the preclinical setting, there was a study looking at imatinib in combination with the CTLA-4 antibody ipilimumab, and this showed synergism. So this led to one of the first trials in immunotherapy in sarcoma, but it included many GIST patients. So 20 of the 28 patients enrolled were patients with advanced GIST, and they were in the majority in the fourth line setting or beyond. So heavily pretreated, and the combination chosen was dasatinib with ipilimumab. And we saw no partial response or complete responses, and the median progression-free survival was 2.8 months. And so compared to the standard imatinib re-challenge of 2 months, this is very similar. Although I think it's acknowledged that when our knowledge for how the immune environment in GIST is stimulated in the setting of imatinib-sensitive disease, utilizing dasatinib in this study was probably not the best choice of therapy, and that I think that further trials utilizing immune checkpoint inhibitors in combination with drugs that are able to yield activity across the KIT mutations would be very interesting to explore. And so some of the studies there are a number of immunotherapy studies that are ongoing or have been done, and one that's there have been interim results published on is a study looking at nivolumab plus or minus ipilimumab. So these are both immune checkpoint inhibitors. Nivolumab, an anti-PD-1 agent, and ipilimumab, an anti-CTLA-4 agent. And so this study incorporated patients with imatinib refractory advanced GIST, and the plan is to enroll 20 patients. At the time when the results were published or presented at GI ASCO in 2018, the interim results were available for 14 patients. And the median number of prior therapies was 4. The objective response rate was the primary endpoint for the study, and at that time, one patient in the combination arm had achieved a partial response, whereas the best beyond that was stabilization of disease. And ultimately, there was a median progression-free survival of 8 weeks and a clinical benefit rate of 40%. The Alliance study is another study looking at this combination in sarcoma subtypes, and it includes a cohort of just patients, and we'll await the results for that. There are other studies that have been are ongoing, looking at pembrolizumab and epacadostat. I haven't been privy to that data yet. And then also we did have a study of pembrolizumab with pexidartinib that unfortunately closed prematurely due to sponsor withdrawal. So that is my roundup of the clinical updates, and if anyone would have any questions, I'd be happy to answer.
Pete Knox, Life Raft Group. Thank you for a wonderful presentation. You mentioned avapritinib BLU-285, one of the adverse events. You know I don't need that data. One of the adverse events was memory issues. Okay, that's been known and been mentioned many times. What also has been mentioned is that it appears to be dose dependent, and that it may in fact be reversible when the drug is withdrawn, which would inform dosing strategies, even dose interruption. Did you notice that in your experience as well?
Yes. Although I guess in terms of dosing, everybody's starting, right now, we're having everybody starting at the recommended phase 2 dose. So I think what probably needs to be teased out are the individuals and their clinical characteristics. Are there any underlying, medical comorbidities that predispose individuals to, to this complication? And in terms of dose interruptions, I haven't seen that myself just yet. So, but I am sure as we utilize this net therapy moving forward, that there may be strategies that we can identify to overcome.
And just to clarify, the memory impairment was patient reported, right? Not neurotoxicological tested.
Yes, patient reported, but I think I think data is evolving in terms of our knowledge, in terms of other potential underlying, neurological abnormalities that can occur as well.
Thank you.
We have time for one more question.
How long since now that both these drugs, CCN285, will be approved drugs for the market?
How long will it take?
How long will it take?
I think we might have to put that towards our industry colleagues to guide you on that further. But I'd be hopeful that these are going to come to market soon. Given the data that we're seeing, they're very promising and clearly have a huge benefit to our patients.
Thank you, Dr. Kelly, and don't go too far away.